I just got a phone call that I need to go to room 205 and assist with some manual ventilation for Mrs. Smith. So on my way, I went ahead and grabbed an Ambu bag and some different oral pharyngeal airways. Upon entering, I knock on the door and I see that the nurses are working on her. I introduce myself. This is Kay from respiratory, and I have my oral pharyngeal airways. The patient's non-responsive. The nurses are working on her. She is very Brady, and it says that her respirations are none. So I'm going to go ahead and just do a quick measure here and make sure that I have a proper oral pharyngeal airway, tip of the ear to the mouth. This one looks like it'll be the best fit. This is a Goodell closed oral pharyngeal airway. So what I'm going to go ahead and do is do a head tilt, insert, and twist at 100, or when I'm about halfway, 180 degrees. So now I have a secure airway for Mrs. Smith, and I have my Ambu bag. I'm going to hook up the oxygen to the bed here and put an oxygen flow on and make sure I have proper head tilt, stay at the head of the bed, and start administering breast to Mrs. Smith. What I'm looking for is proper chest expansion and bag refill. I want to administer 12 to 20 breaths per minute. Mrs. Smith was a CHF patient. It's going to be 8 to 12 breaths per minute. You don't want to hyperventilate CHF patient. So I would continue doing this just until we await further instruction. I have the oxygen hooked up to the bed, so if we need to go to the OR or go somewhere, I'm all ready to go. I can do this as we are moving. But I will just monitor her SpO2 and see if there's any spontaneous breathing, and I can administer the breaths while I do that.